Hello everyone, I am Dr. Mohit Sahni. Welcome to NfECHO Neonatal Focus Echo Academy platform. On this platform, we bring small presentations every week to update you on neonatal hemodynamics and echo. At NfECHO Academy, we provide hybrid, online, and physical hands-on training of neonatal echoes. Kindly contact on the given contact details that is running scrolling. Kindly subscribe and like the channel. For more details, please see the description. Thanks for watching. Hello everyone. Welcome to NfECHO. Today's topic is what is this fECHO? F focus echo, functional echo, whatever you say, and why it is important. So before moving ahead, please share this video, like this video, and press the bell icon. So now let's talk about what is this fECHO is, that is focus echo. So basically the focus echo is nothing but a focused ultrasound for the evaluation of your cardiovascular system. It is not the replacement. It is just another tool in addition to your clinical judgment in the hands of the intensivist who is taking care of the sick babies. And it is not just there to support your clinical judgment. Once you have judged what is the problem, you have started the treatment, and then you can revisit the problem to see what is the response to your treatment. Therefore, it improves your clinical diagnosis and hence your patient care. And this is being published in the article in Journal of Pediatrics and has been taken from there. This is an established terms like it has been published in American Society of Echocardiography in the journal as TN echo, targeted neonatal echoes. So the nomenclature may be different, but the concept is same. So when we see why it is needed, why it is important. So just compare the data of India, which we say is a resource limited country. Now in 2022, it is better, but this data is comparative data of 2005. At that time, it was still very much comparative because the resources were still limited at that time. You can see the most of the diagnosis, antenatal diagnosis was CHD were missed, and there are very limited number of pediatric cardiologists available to take care of these sick babies. Our training programs have been started very late, and still we don't have a structured training program for neonatal echo. Only we have been doing workshops. So NfECHO provides a platform for that training. We did a comparative survey in Canada, Australia, New Zealand, and India. And as you can see in these graphs, in Australia and New Zealand, neonatologists were the main people who were doing the focused echo or echo in the NICU. In Canada, pediatric cardiologists were predominantly doing that. In India, adult cardiologists were predominantly doing it because their skills were, and pediatric cardiologists were not readily available in the country. So that again initiates the discussion that why the intensivist should start learning this skill. Why it is so? Because there are a lot of hemodynamic problems that preterms, if we talk about newborns, a preterm can face. So those can be the transition from the fetal life to the neonatal life. High pulmonary pressures can be there because of severe RDS. PDA again is a big problem in preterm babies. They may go into shock because of various reasons. They may develop pulmonary hypertension in chronic lung disease. Then again in preterm, we have to rule out congenital heart diseases. Need to see head ultrasounds. The lines we place, we should see where the tip, what are the complications. And when, as you can see in this slide, we are assessing for clinical problem, we do the functional evaluation. If there is a hemodynamic problem in that, we start some treatment. After taking this medical decision, we can revisit to see whether what we have done have made the change or difference or not. While evaluation, if you feel that there is an anatomical issue, then you need to involve the
pediatric cardiologist. It is very important because they are the trained and certified people to tackle the anatomical issues. And as you can see in few of the data from the various in this published studies, that how this focused echo has made difference in the clinical judgment, what plan you have made after clinical judgment. So whether it has changed that plan or not. In case of PDAs, clinical plan after assessment, a clinical plan was been made. And then after doing this focus echo, 40% of the babies, we need to change the plan, what we made after clinical assessment. Similarly, in babies with shock, you can see more than 90% of the clinical decisions we made were changed. And in pulmonary hypertension, again, 40% of the decisions that were made after clinical assessment were changed. Let's talk about one scenario. This is 26-week preterm baby born to normal primary by normal vaginal delivery, cried immediately after birth. There are no antenatal issues. Appropriate antenatal steroid cover was been done. Developed RDS at birth, hence was given CPAP in the delivery room and then shifted to NICU. In NICU, CPAP of 6 centimeter with FiO to 40% was started, and these vitals were normal for that age and gestation. And one point, always check the SpO2s in the right hand, that is a preductal. This baby started having desaturation, developed mottlings, and became off color. So what are the reasons for this mottling and becoming the baby going into shock or becoming off color? Basic things first. Dope. If the baby is on positive pressure ventilation, always rule out the pneumothorax and obstruction. And whether you should judge and see whether the primary disease, that is HMD or RDS, is worsening. Rule out IVH and rule out the other causes of shock. So all were ruled out. Still the perfusion was poor. So we wonder what may be the cause for it. So how to manage fluid boluses and all the inotropes and all those things we need to know. But from where we get the answer? Okay, because all these things if we do, if we baby does not improve, from where to get the answers? Boluses and inotropes, as we have discussed, we don't know what to start. Dopamine, dobutamine, adrenaline, milrinone, which is the right one for this baby. Hence, you have potpourri of whole confusion of inotropes. So that's the point when we need answer, and that answers can be given by this fECHO. And therefore, we need to learn this skill to tackle that which one to use from this inotrope soup. This is just a table which gives you an example that how if you have a clinical, this is the clinical parameter, okay? And this is a parameter you assess by the functional or focus echo. So suppose your blood pressures, which is a clinical parameter, is normal. Your cardiac output is normal. Then you need not do anything in this baby, just observe. If your blood pressures are low, but your cardiac output is high or normal, so that may be the shunt, as in the premature babies it is common. Then you need to treat the shunt. If you have a high or low normal blood pressures but low cardiac output, so that shows there is high afterload. You need something which is inodilator. If you have low blood pressure and low cardiac output, is the most common example is septic shock, mixed shock. You need a combination therapy. So that's why it enhances your clinical assessment. So my friends, if it is raining, the raining is nothing but a troubles you get in an ICU. And if you have something to tackle that, tend to use it. Don't preserve it for future. So thank you very much. And please subscribe our channel and share it. And if you're interested in learning the echoes, so you can contact us on the WhatsApp number or the email for the further details of the courses. Thank you very much.